hello, everybody. One of the most interesting and fascinating postings I had as a medical student really was my psychiatric posting.
That's good.
And as we know, mental illness affects our mood, our thinking, and our behavior. We all experience periods when we are stressed, worried, anxious, sad, afraid, or angry. But this doesn't last long to the point of affecting our ability to function. Everyone has some risk of developing a mental illness, no matter their age, income, religion, or ethnicity. There are many risk factors. Some risk factors of developing mental illness are, things like genetic factors, traumatic experiences, alcohol and drug abuse, and so many others. And now we understand that COVID-19 itself may be a specific factor, despite the high prevalence of mental illness. It is a neglected disease. So people are stigmatized. So talking about it is very difficult. Today, we have experts in this field to enlighten us and answer our questions. This is the fourth webinar organized by COVID Nigerian medics in an ongoing series to highlight challenging healthcare issues during the COVID era. It is a privilege to introduce the organizer of today's webinar. He is a consultant psychiatrist in the UK. He's the founder and CEO of Steno Memorial Foundation, which is a registered NGO in Nigeria that provides medical, surgical, and educational outreach programs. He's a true example of what we in the diaspora can do to contribute in rebuilding our country. Please, let's welcome Dr. Femi Sani, and he will be introducing the other panel members. Over to you, Dr. Sani.
Well, thank you very much, Sadia. And hello, everyone. Thank you for joining us for today's webinar. This is the fourth edition of our COVID-19 Nigerian Medics webinar series. Like Dr. Shadia just mentioned, we're talking about COVID and the impact on mental health. I'm really excited about today's webinar because we're going to be talking about what is significant and what is impacting on every one of us. We have interesting topics to talk about and very knowledgeable and insightful presenters. Before I introduce our first presenter, I would like to introduce my co-moderator in person of Dr. Jubril Abdul Malik. Dr. Jubril Abdul Malik is a senior lecturer with the Department of Psychiatry in College of Medicine, University of Ibadan. He's also the founder and the CEO of Asodo Foundation, a not-for-profit mental health advocacy organization. I will really encourage every one of us to pay a visit to the website. It's www.asido, is spelled ASIDO foundation.com. Dr. Jubril and the team work in advocating for mental health. And I'm sure you'll find a lot of their work on the website. And I will encourage us to support them because they're championing the cause for people that are vulnerable, people that are not paid attention to in our community. Also, Dr. Jubril Abdul Malik contributes to a weekly column for Nigerian Tribune on Thursdays, and this is titled Your Mental Health and You. And again, this is something I will encourage us to read about, to pay attention to when we buy a Tribune on Thursdays. Is a very interesting column to read. you will learn a lot about your mental health and other practical measures on how to continue to live with a stable and adequate mental or emotional well-being. He also has been running this column since 2016. He's also an author, the book titled Optimal Mental Health, an Everyday Guide. You can see he's someone that is very busy and in the area of mental advocacy and support. And I'm going to hand over to Dr. Jubril Abdul Malik, and it's my pleasure to have him with me today to co-moderate today's webinar. Dr. Abdul Malik, over to you.
Right. Thank you very much, and good evening, distinguished listeners. It's my pleasure to be part of this and to really appreciate the work of Dr. Sadia and other colleagues with the COVID Niger Medics efforts. And just to quickly add before we get started, that these are the kind of diaspora and at-home collaboration Hello, can you hear me?
Yeah, we can hear you.
Yes, please.
Okay, right. That leads to strengthening of our efforts as well as improvement of the health sector. But I mean, let's crack in very quickly because we have an excellent array of brilliant colleagues who are going to talk to us today. We have my senior colleague and big brother, Dr. Victor Makonjola. We have my sister from Jos, Dr. Aisha Miao, and Dr. Apologies, I don't know, there's a slight glitch. So Dr. So we're going to take them in that sequence. Dr. Victor Makunjola will speak first, Dr. Aisha Mia will speak second, and then Dr. Raphael Emeka Ugbolu will speak third. So let me just introduce Dr. Victor Makunjola. So we will have each speaker speak for about 10 to 20 minutes, and thereafter we will have an interactive session after the three speakers have spoken. So we hope to wrap it up by 6 p.m. Definitely for sure. So Dr. Victor Makonjola, it's my pleasure to introduce to you Dr. Victor Makonjola, who is a consultant psychiatrist and senior lecturer with the Department of Psychiatry, College of Medicine at the University of Ibadan. He's also the Deputy Chairman, Medical Advisory Committee in charge of clinical services at the nation's premier teaching hospital, the University College Hospital, Ibadan. He will be speaking to us about telemedicine implications for mental health practice as a result of COVID-19. The three speakers are all related to COVID-19 and mental health. So in this series of lectures by COVID Niger Medics, today's edition is focusing on mental health. And it's my pleasure to welcome and invite Dr. Victor Makonjola to share his thoughts with us. Thank you very much.
Good evening all, or good afternoon all. Thank you very much, Jibril, for that introduction. May I also echo Jibril's comment about the great work you guys are doing over there, Femi, Sadia, putting this up, and this being the sort of collaboration we appreciate with the diaspora, with our colleagues in the diaspora. Of course, I'm very much aware of all other efforts of Femi in bringing healthcare to the people of his constituency and beyond through the Steno Foundation, and of several other people who are supporting him from the UK and also in Nigeria in making sure that the dream of his foundation in improving healthcare in his state is realized. So we appreciate you for this. Let me move on to the main topic of my talk. looking at telemedicine, the implications for our practice, as this going to be a regular part of our life as we're moving on. I will follow this outline. The picture we have right now with COVID-19 strongly suggests that this is going to be a marathon, as has been predicted. No quick fixes. We're having new lockdowns in Europe and also in some parts of the United States. So it's obvious that it's going to be around for quite some time, and that will make it imperative for us to change the way we live. We need to adopt new behaviors to prevent infection as part of our daily life. We need to begin to wear masks in public anytime we go around in public. We need to maintain physical distancing as opposed to the earlier language of social distancing. Physical distancing does not necessarily mean you are socially distant from people, because there are other ways of keeping in touch other than the physical part of it. Of course, teleworking, which is what I'll be focusing more on, will also become a major part of our lives going forward. And of course, good hand hygiene, it's something we all need to adopt. These basic steps in preventing infection will become part of our daily life. And they are not only good for COVID-19, but they will also prevent several other infectious diseases going forward. Teleworking essentially is working from a remote site from your office, usually your home, in the comforts of your and confines of your home. And it's somewhat not so novel for those who work in the technological industry, software developers and the rest. I've been working from home for quite a while, even before COVID. But now it's going to be more extensively deployed by every one of us, even those not working in COVID-related industry or engineering-related industry. Even else may also have to start working from home under some certain circumstances. Now, in working from home by a doctor, so we're talking about telemedicine, and now it has been deployed over the years. It's essentially the assessment and treatment of our patients without physical interface, without the face-to-face contact, often using modern communication gadgets. And the WHO had referred to this as healing from a distance. It's not such a novel thing. It's just that now COVID-19 is going to force it upon even the biggest cynics of technology. We all have to adopt it. As far back as 1879, it's been reported that telephone can reduce number of unnecessary office visits. But with COVID-19 now, we're not only talking about telephone in terms of audio, video conferencing is also going to be a major part. So the full consultation experience may have to be deployed through technology. And that is what COVID-19 is ensuring that we adhere to or add to our regular bouquet of seeing patients. What are the types of telemedicine? The one that is really important to psychiatry is the interactive medicine, which allows patients and their physicians to communicate in real time, usually by video conferencing. The other forms that deploy the monitoring chronic non-communicable conditions like diabetes, hypertension, and the other conditions that we may have. But what is unique to psychiatry is the interactive medicine part. And what are the gadgets that are often deployed in telemedicine? Computer and mobile phones are going to be the primary tools in interacting with our patients. And other gadgets could be used, especially when the other parts of medicine are involved and you want to monitor how a patient is doing remotely. So all these digital stethoscope, pulse oximeter, and the rest could come in. But for psychiatry, mobile phones and computer systems that are video enabled are going to be the primary tool we use. Telepsychiatry, which is a form of telehealth, a form of telemedicine, involves providing psychiatric care to patients via any form of telecommunication, usually audio or video conferencing. And it involves all the bouquet of what we do, even in the one-on-one or one-to-one rendering of psychiatric services. It will include evaluations, psychiatric evaluations, offering therapy, psychotherapy, group therapy, family therapy, all could be deployed through telepsychiatry. Psychoeducation as well, we continue, even through telepsychiatry, and then medication management, adverse effect monitoring, side effect education, and all that. We all so could be deployed through telepsychiatry. And beyond direct patient care, you may also be able to be involved with patient care secondarily through a primary care provider that you advise and guide through a process of evaluation and treatment initiation in a remote area, completely far from where you actually have your practice. Now, what are the benefits of telepsychiatry? These benefits listed are all supported by strong evidence, but very strong evidence from usually the developed world where Femi and Sadia resides. So, I'm going to challenge some of them as we go down the line as to probably if we deploy telepsychiatry, say in a low and middle income country like Nigeria, would we be getting the same results as those that have been reported in those studies? Also, to let you know that those studies often deploy telepsychiatry with funding backup for the service. And then you evaluate and say, oh, it's quite good, well accepted and all that. If you remove the funding, would you still have the same satisfaction? Would you still have the same accessibility? All that I will probably mention down the line. But we know for certain that it increases access to care, especially for those who reside in remote areas, rural areas, villages, very hard to reach population in remote parts of the countries, have been shown to really benefit from telepsychiatry and from other forms of telemedicine. It's also cost effective because if you put into the picture the logistics of bringing a patient from a rural or remote place to the city, even the transportation cost alone is enough to offset what other costs you might have to deploy in terms of gadgets and technology. So ultimately, it's bound to be cost effective, and it's been shown to be cost effective in several climes. Also, it's quite flexible, and there's good return on investment when deployed commercially. When you have a platform that runs a telepsychiatry service to a group of clients in the catchment area, there's also very good return on investment, especially on a private basis, or in areas where the insurance covers such consultations. It could provide very good yields. It's also been shown extremely important that it as effective as one-on-one delivering of services in many studies. Several studies have shown that it could be as effective and even sometimes even more acceptable to clients compared to one-on-one services. In a country like Nigeria, looking forward, looking at our new normal, all these benefits gives one sort of an optimism that if we deploy in Nigeria, it's going to be a good thing and we're going to have good results and all that. To further increase the optimism, you look at the internet penetration and full subscriber info that we have about Nigeria. 46.6% of the population have internet access. That is what we have as far as 2020. And then this is set to reach 65.2% in 2025. Now, that gives you a lot of optimism that you could reach a large population of Nigerians. Secondly, 170 million mobile subscribers or mobile subscriptions exist in Nigeria. That also gives a lot of positive vibe to deploying internet-based service or or mobile phone based service. But a little critic of these figures is the fact that what is being documented is number of subscriptions, not number of Nigerians who have access. Because out of 200, if we have 170 million with access, that is fantastic. We can deploy anything, internet or we will reach a large number of people. But out of these 170 million mobile subscriptions we have in Nigeria, an average Nigerian has about 3 lines. So you can decrease this figure by 30% or divide it by 3 to come close to the real number of Nigerians with mobile subscriptions. Average Nigerians have 3 lines. There are people with as many as 5 to 10 lines, and you wonder why that has to be. There's poor services by all the internet service providers and mobile service providers. So you may need more than 1 line to maintain your access to people. And then you find that in certain areas of a city, there's poor access to one mobile subscriber, good access to another. So that has compelled a lot of Nigerians to have multiple phone subscriptions. So these figures are to be taken with some bit of cautious optimism. They are not a true reflection. Nevertheless, they are also still good in the sense that at least quite a number of Nigerians have this subscription. And if we deploy, we will have a sizable number that is able to log on to services. What are the disadvantages? When you do telepsychiatry, there'll be fewer face-to-face consultations with its own drawbacks. The major appeal of psychiatry, the major healing effect is also in the relationship we have with the patients, which is likely to be more impactful in a one-on-one consultation than in telepsychiatry. Policies are unclear because technology grows so fast that the policies are not catching up with the growth. Technology is also expensive by itself, but we've talked about cost effectiveness. Even though you may spend a lot to acquire the technology, when you look at the other costs that you eliminate by deploying the technology, it may actually be cost effective at the end of the day. Now, I'll go through these few issues, especially in the context of Nigeria, which just to get us thinking about how acceptable and how feasible would be for us to practice telepsychiatry, the way COVID-19 demands that we have fewer people in the clinics and fewer people, having one-on-one contact. Start with appropriateness of patients for telepsychiatry. Not all patients will be in the category of those you can deploy telepsychiatry for. For one, patient features such as being disorganized, being an uninsightful and involuntary patient, it might be difficult to get such a patient to come to an agreement to have a consultation via a mobile phone. Affordability could be an issue. We've talked about technology being expensive and those figures of mobile subscription being exaggerated because an individual has multiple subscriptions. Accessibility, even though it's been shown to increase access to rural community in developed world, I strongly suspect this will not be the same in a place like Nigeria because the rural communities even don't have masks. So there is no way you're going to deploy to effectively to those rural communities. And it's because communication right now is in private hands, it will be difficult to convince an investor or an entrepreneur to put more masks in the rural areas when the income from the whole rural area, as vast as they are, might just be equal to that of a densely populated town or city. So that would be a challenge. And that means more rich people who live in cities, who are already privileged in several ways, we're going to be increasing their access to psychiatric care compared to those who are actually deprived, poor, and living in rural areas. Also, the issue of willingness to pay will come in, especially for those who might be practicing privately. Are patients willing to pay for telepsychiatry, for video conferencing, for being consulted over the phone, as they will be willing to pay for physical consultation. I know patients who would rather drive down from Lagos for 30 minutes, 1 hour consultation with me privately than to have a video conferencing in the coolness of their homes and in Lagos, and just pay for the same thing. So there will be certain unwillingness to pay for telepsychiatry. Regulation of practice would be an issue. Currently, the physical uh, service that we're running, in not just in psychiatry, in the whole of medicine in Nigeria, regulation is an issue. There's quackery everywhere. And now if you're moving on to an online platform, this will even be multiplied, let's say 10 to 100 folds. Do we have the capacity to regulate the practice when we go online for most of the consultations? That would be a question hanging in the air. But it's not very difficult to see that we're going to struggle with that. Currently, even paying for your license and all that is quite challenging, meaning that the regulatory bodies are not even in tune with technological advancements, talk less of now regulating another technological platform. Or then we talk about competence, credentialing of providers. It shouldn't be assumed that a good psychiatrist on one-on-one interaction, we also remain a good psychiatrist when it comes to delivering service over the phone or via video conferencing. Of course, there would be issue of a poor legal framework for rendering the service. Informed consent might also be an issue. We're able to clarify whether the patient was coerced or forced when they come one-on-one, but you wouldn't see what is happening behind the screen if you're doing teleconferencing. Perhaps there's a cane being held behind the screen, telling the patient he must say this or he must comply with conversing with you. So that may also be a drawback to telepsychiatry. Privacy and security matters will also come in. We all sign, I agree. In fact, we click I agree without reading the terms and conditions of most apps. Could these apps have access to our conversations with our patients? Could they record conversations with patients? And could we have hackers hacking the platforms we use and then using the material against the interest of our patients? We can just imagine a governorship candidate having a video of his private consultation with a psychiatrist being leaked on YouTube weeks before an election. Those are the sort of challenges we may have to face if we deploy telepsychiatry. Of course, risk and compensations issues will come up. And payment arrangement for practitioners and appropriate billing too might be a challenge. As doctors, we tend to think we know how to bill, but oftentimes we're really doing this. Would we need an accountant, a cost accountant, to help us actually factor in all we need to put into our bill to arrive at an appropriate billing, such that we're not just rendering service and being poorly compensated for those services? Those are the sort of challenges we're going to have going forward, and in trying to upscale telepsychiatry and access to care for people with mental health challenges, especially in this COVID and intra and post-COVID era. So these are things we will really have to give a lot of thoughts and prefer solutions to. In summary, telepsychiatry is highly desirable and is inevitable in view of the challenges posed by COVID-19. So we definitely have to deploy. To what extent what will be our challenge, and to what extent we are able to surmount some of those challenges I mentioned. Of course, currently there's still a lack of legal and regulatory framework in Nigeria. And then there will be issues of justice as regards accessibility. Are we only increasing access to the affluent, to those who have money, who are already privileged? Are we just increasing access to them, or to those who really need the access, who have never had access in the rural poor, as we say? The poor of the poorest, that is a terminology common now in Nigeria. Those who palliatives were meant for, but never got to them. And then is affordability going to be a universal fact? It's not universal that people will be able to afford telephones, especially smartphones. There's a rate of about just 10 to 20% of Nigerians have access to smartphones, which makes conversations a lot easier and more complete. So with all these, I think provides a platform for further discussions on how COVID-19 is going to affect how we live beyond this point, especially with regards to making consultations for mental health issues in Nigeria and probably in other climes as well. Thank you very much for your attention.
Wow, that's a fantastic tour de force. Thank you so much, Dr. Victor Makonjola, the Deputy Chairman, Medical Advisory Committee of the University College Hospital Ibadan, which is, of course, the premier #1 teaching hospital in Nigeria. Apologies to others who are not in UCH. So, I mean, he has given us a real tour de force in terms of experience and the issues we have to deal with respect to the attractiveness of considering telemedicine in view of the high internet penetrance, the fact that we have up to 170 million mobile subscribers, but keeping us cognizant of the challenges that we may lose the patient-client interactions considering the unique nature of psychiatric practice and the unreliability, the technological challenges, and the fact that it can be hacked and so on. And then looking at how feasible this may be with respect to competence, credentialing, the fact that it may not be equitably accessible to everybody with respect to cost and so on. And he has ended up by challenging us that these are issues we need to discuss. We are coming back to the interactive session when we will all be able to contribute to this. So thank you very much, Dr. Makonjola. Please don't go away yet. Please, we'll come back to you during the interactive session.
All right. Thanks.
So moving on quickly. Thank you, sir. It's my pleasure to invite our second speaker, who is a distinguished psychiatrist and my sister from the North, Dr. Aishatu Armiao from the University of Jos Teaching Hospital. Dr. Aisha has a master's degree in forensic psychology and criminal investigation, and she recently earned a PhD. I'm very proud of her for that, from the University of Nicaragua. And currently she works as a consultant forensic psychiatrist at the University of Jos Teaching Hospital. Dr. Aisha Armia is a very brilliant psychiatrist, and you will very soon see that for yourself. And she will be speaking on mental health challenges during COVID-19 and future pandemics. Dr. Aisha, you're very welcome, and you have the floor.
I mean, whether we can give her a chance, is there someone that can present? And while we fiddle with this.
I'm just going to share my thoughts about the impact of COVID-19 on our older adults ones. As we know, in terms of the significance of these unprecedented times over the world, the most vulnerable ones have been seen to be the elderly ones in our communities. From my experience as working in liaison psychiatry, looking after older people as part of my part, I've seen that we've seen cases of elderly ones that have come with no previous history of mental health condition and struggling because of the lockdown restrictions. They've found it difficult to have the opportunity to have the one-to-one social inclusion with their families, with the community, being told to self-isolate, being told to shield themselves because of their vulnerability. This had led to significant psychological distress, and then is also giving us another thing to think about in terms of how we protect them and how we continue to look after them. And I think it is interesting that Dr. Mark Ojola mentioned telemedicine, and telemedicine in terms of providing some sort of access to care that was available during COVID time. I was involved with in our services, being able to provide some support to our elderly ones who are isolated, so that they can have some kind of assessment and adequate management care. It is also important to know that it increases the risk of self-harm and suicidality. And then we know that our elderly ones, they don't just cry for help when there is no reason to be. They don't want to be a burden to you. They only ask for help when they do really need it. And that it is important going forward as well. I also want us to be mindful of the fact that with regards to progression in some that have got possible cognitive deficit, we've noticed that during this COVID time, even those that have just got just mild cognitive impairment, they went on to develop a significant dementing illness. And we know that in people that have had mild cognitive impairment to develop into a progressive and significant dementing illness take about a year, depending on their comorbidity. But with the pandemic, it became more accelerated, so to say. And then some of them that had also physical health condition needed to be admitted or into hospital, or GP needed to treat them for maybe just UTI or just chest infection. They never got back to the baseline where they were before they had such condition. So it is also important to bear that in mind. I just said I should share my thoughts around that, and also to be mindful of the fact that the COVID pandemics has had a significant impact on their well-being. Thank you.
Thank you very much, Dr. Femi Sani. I was going to say Dr. Skenki.
Our next speaker is Dr. Raphael Obolu. He's a consultant psychiatrist, coordinator of Suicide Research and Prevention Initiative, SERPIN, in Lagos University Teaching Hospital. Unfortunately, he's not able to be present here, but he sent an audio recording of his presentation titled COVID-19 New Norms, Implications for Suicide Risk. Enjoy listening. Thank you.
My name is Dr. Raphael Emeka Obolu, and as has been mentioned, I'm a consultant psychiatrist and the coordinator of the Suicide Research and Prevention Initiative, SERPIN. I will be talking on COVID-19 new norms, the implications for suicide risk. To start with, I'd just like to remind us all about the WHO target, which was to reduce global suicide by 10% by 2020. Now, when this was set years ago, we thought it looked far away, 2020, but now 2020 is coming to an end, and unfortunately, I mean, the whole global pandemic, COVID-19, seems to have set the world back with regards to this target set by the WHO. But it's important that we keep that in mind, that this was originally the intention. It is still a target at the end of 2020. Well, the statistics will show how much we have accomplished towards this goal. Let's look at, just to remind ourselves of the rates. Globally, suicide is said to account for 1.5% of global deaths. For each death, about 20 to 25 people will have attempted, and about 85%, well, 78 to 85% of the suicides occur in low and middle income countries. Unfortunately, data is largely unavailable for about 73% of developing world, including most of Africa. In Nigeria, just to tell us how far we have come, as far back as 1962, ASUNI reported rates of less than 1 per 100,000 of the population. As at 2012, this was 6.5. And by 2015, this was 9.5. So we can see, yeah, we do know that, of course, population has grown, but this is a rate, okay, irrespective of that. And that's just telling us that the suicide has actually been on the rise in Nigeria, even though we haven't paid much attention to it. Now, let me just give you some facts based on Serpin's experience. By the way, I mean, Serpin is, as I mentioned during my introduction, an initiative that was started in 2017 with the aim of trying to address suicide in Nigeria. And it has several activities, including hotlines. It conducts trainings and it collaborates with other NGOs towards promoting mental health, particularly those things that contribute to suicide. So our hotlines, which are available in the major networks, 4 major networks, and we receive calls from all parts of Nigeria. So this is just highlighting the calls we've received from inception when we started in March 2017. And you can see that in the upper part of the table, between January and June 2020, we have received 29% of all our calls, and that's a year that hasn't ended. So, of course, we update these figures at the end of every 6 months. So by December, we will. But that's telling us something. And if you look at the lower part, in May 2020, we received the highest number of calls for a single month. And you remember that coincided with the whole period when this COVID-19 thing was really a problem for people. We did realize there was an interesting observation we made. We found during COVID itself, calls to our hotlines actually dropped. But immediately after the first lockdown was lifted, calls rose. Now, there are several factors that may have contributed to that, but it clearly tells us something about people having to deal with the aftermath of the lockdown and COVID-19 and a lot of the other factors which we're looking at today. Still looking at the facts regarding Serpin's experience from the hotlines. When people think about the things that could possibly push people to contemplate ending their own life, of course, I'm sure most people think of financial being the far leader, but we found that aside from, yes, there were financial reasons, but also relationship issues were major problems, bereavements, family conflicts, partner infidelity, LGBT issues. So those account for other factors, but clearly, financial and relationship issues were in the forefront. Now, only this year did we have financial problems overtake relationship issues. From inception, they were almost equal, and at some point, relationship issues were actually the greatest reason for which people called our hotlines, and that's telling us something. Again, the financial impact of COVID may have caused the change in trend, but that's for us to think about, and these are the facts. Of course, you find that about 70% of those who did call had thoughts of ending their own lives, but not many of them had plans, and that's supposedly, I say, a good thing, so to say. Having looked at the facts from our experience from our hotlines, and seeing that amongst the reasons why people contemplated ending their own lives, included, as I mentioned, financial issue, relationship issues, and health issues, amongst other reasons. So what are the COVID-related factors that may be driving these reasons? Clearly, social isolation must have been a major problem. Why we will have seen some of those reasons increase and continue to be prominent amongst why. Bereavement, a number of people did lose family members, people, friends, acquaintances, people that they knew. A number of people did lose people to COVID-19 and COVID-19 related conditions. The lack of distractions. We can't, I mean, we tend not to really appreciate the importance of being busy. When people had to go out, interact with other people, that keeps a lot of people distracted from things that would otherwise drown them in their own sorrows or worries. And the lack of that, especially during the lockdown, really didn't help. The breakdown in social support system. I mean, people have their own little support networks, friends they would meet, people they would meet in church or in the mosque after service, people they would meet up after work, things like that. All of those little social support systems broke down during the COVID-19 lockdown, and even after that, some haven't recovered from the impact. Worsening chronic medical conditions, and people at some point couldn't go to the hospital, okay, who had chronic debilitating conditions, which themselves, can impact the mental well-being of the person. Worsening mental illness itself, yes, I mean, mental health treatment was not exempt from, the impact of COVID-19 when people could not access services due to so many factors. The rise in impulsive suicide attempts, anxiety and drug abuse most likely drove this impulsivity. Just to briefly mention, you can group suicide into two types: the premeditated, or planned suicide attempt, and then the impulsive one. Now, people tend not to remember that suicide can actually be impulsive, not always planned. And there's some suspicion that during COVID-19, there may have been a rise in impulsive suicide attempts, and this may have been driven by, as I mentioned, anxiety and drug abuse. Financial downturn, people lost businesses, couldn't pay back loans, people lost jobs, and all of that as well as a result of the global financial impact of COVID-19. Relationship strain, that's also clearly something that was a significant factor. People now having to be cooked up in the same place with the person whom you have a bad relationship with, or people who distance hasn't helped their relationship and they can't get across because of COVID. So it could be a strain on either building a relationship or getting away from unhealthy relationships. So these are some of the COVID-related factors. I'm sure we can think of a number of other ones, but these are the ones that seem to play a factor in driving the reasons why people called our hotlines. Again, drawing on facts, not hypothetical situation, based on our hotline experience. Let's look at those mental health conditions that we did find among those who did call in, who we were able to screen or assess. And these are the outcomes of those factors we've just mentioned and those reasons for which they called. So depression was by far the highest, more than half. Then we did have a number of people who had substance abuse issues, and other factors as well. Then, of course, we had to provide intervention. More than half of them we linked to the nearest mental health service in the country. Some were asked to visit the Serpent Center. Some we contacted significant relatives. Other interventions such as phone counseling. What I'm trying to bring about here is, and this is not, bear in mind, this is cumulatively, all right? But we have identified that during this year alone, we have had an increase in number of calls to our hotlines, more than previous years, even though that's a half year figure, so we expect it to increase. So while all of this is not totally accounted for by COVID, but these are trends that are clearly influenced by the increase in calls we received during the COVID as a result of the whole global pandemic. So it's clear that depression and drug abuse remain very important factors. Having looked at all those factors, why should we be concerned? What are the aspects of this new norm in relation to mental well-being? Well, the first thing is healthcare fatigue and recovery time. Definitely a number of healthcare professionals, including mental health professionals, have been impacted variously, and the healthcare system may suffer fatigue for a while in this new norm. It may take a while to recover from that healthcare fatigue. It's been quite stressful for quite a number of people, those who have been in the forefront and then other people as well. So that's something we have to contend with in the new norm. There will be a number of people whose socioeconomic standing has changed in this new norm. As a result of economic downturn, loss of job, businesses folding up, unable to pay loans that have gone bad. So a number of people will find themselves no longer where they were before COVID. Some will continue to have persistent illness anxiety related to COVID-19 during the new norm. Some may have now become quite germ conscious. Okay, some who had OCD traits, now in the new norm where people still have to socially distance, people even after the world seems to have felt we're in the clear, there will still be a tendency for people to still be cautious, face masks, gloves, all those infection control things, and this could really affect people who already have obsessive compulsive tendencies. So in the new norms, there might be persistent illness, anxiety, stigma. Now that's something we already, we know a lot about in the field of mental illness, but then just some may not be aware. But it's almost similar to the Ebola crisis. People who have recovered from COVID-19 may face some forms of stigma, and we mustn't downplay that. And that's something that, so people may begin to hide, the fact that they ever had COVID and things like that. But that's a new norm, because people may begin to see COVID-19 as an identifier, a new identifier for people. Oh, that's the person who had COVID. And so that's going to be a problem as well. There's the rise in virtual living. It's been good in some aspects. People have been able to have meetings online. People have been able to have conferences, talks, so many things, even consultations virtually. But what's the other side to that? We are becoming more distant, and that's the new norm. Companies may decide to continue along this line where staff members can work from home. People can still work virtually using different platforms, which has its advantages in terms of lowering costs and things like that. But at the same time, it's just taking us farther away from our face-to-face contact, and that itself has implications for mental well-being. People who the only social contact they had was going to school. Some lectures may remain virtual now. Going to work, now they can stay at home, and they will lose that social awareness, those social skills. And it's possible, and that itself is not very good for mental well-being. There's this lack of escape that some people have described. Again, it may not be, a number of countries will become more stringent, stricter in terms of people seeking visas to enter their countries, immigration, emigration, all those things will be affected in the new norm. And some may see it as lack of escape. Those who feel that they want to go to other countries for greener pastures, and that could impact some people. That's all they've been living for, and now the doors may have begun to shut and may remain shut even in the new norm. There's certainly an increase in fraudsters, an increase in victims because of the whole risks of people. A lot more people are online, and so there are a lot more victims online. Okay, and so you have a lot more fraudsters looking for victims online. People would seek fraudulent means of recouping their losses from COVID. So that's also people who become victims could be mentally impacted. And then there's the other one, which really is a concern, which we haven't yet begun to see because schools are only just reopening. ASU has been on strike, and that's the academic factors. Now, there are people who will have to repeat classes for no fault of theirs. Some of their colleagues who may have traveled out or who may be in schools that found their ways around, so those ones may not repeat. So peer comparison, we were in the same class, now because of COVID, my school couldn't keep up, yours did, you're in the higher class. Some will struggle academically, some who have seen themselves through school, who have been funding their own school. This whole period has affected them. How will they pay for their school fees? So there's a lot of things that will come when schools return at all levels, and we need to be aware of that as well. If I may summarize the end result of all of this, it will be a decline in individual, collective, and collaborative resilience, which is something that should concern all of us. All those factors mentioned in the previous slide, clearly this is where they might end up. And we do know that resilience is promoting and building resilience is one thing that could help protect people from mental breakdown, and that has been the focus of prevention strategies worldwide. So we need to be aware that this might just be the end result. So what are the implications for managing suicide risk? As I mentioned, number one, impulsive suicide attempts may rise, and it's difficult to manage prevent impulsive suicide attempts unless one is fully versed in recognizing the risk factors. But it's always, most of the time we're better equipped to prevent premeditated suicide attempts compared to impulsive suicide attempts, and we might just see a lot more of impulsive suicide attempts. So that's an implication for managing prevention. Then the other thing is linking people up with mental health services. That clearly may be impacted by the whole COVID-19, the whole new norm, because people may still be a bit wary about of face-to-face contact, going far, traveling far distance to meet up with mental health professionals and things like that. Clearly, brain drain will remain a problem, and the new norm for anything, as we've seen already, countries are attracting people because they need them. And so that's going to affect those who should be in forefront of suicide, managing suicide, and even general mental health services as well. So that's an implication for managing suicide risk. Also, poor insurance cover, which has been a problem, okay, but it has greater implications now. The NHIS covers virtually does not cover mental health, and so especially when people are now have always been expected to pay out of pocket, and a number of people may face financial downturns as a result of the impact of COVID-19. How then do they pay for mental health services? So they might break down, worsen depression, worsen drug abuse, and then of course these can drive suicide itself, and then make it a lot more difficult to manage because people cannot seek help because they cannot afford to seek help. The other implication for managing suicide risks is an increase in quackery. Now we're going to see, we already had begun seeing a lot more of this. A lot of people calling themselves all sorts of names. You do one short 5, 3, 2-month course, 6 weeks, and you call yourself some name, and you enter the mental health space, and that's very dangerous. People who have no skills in managing psychosis or other severe forms of mental illness have waded in, and it's going to increase now because of the virtual world that has expanded, and so we expect quackery may increase, and this has implications for managing suicide risk as well. So it has sounded quite bleak, but I just want to say that it's not. I mean, yes, there are a lot of reasons for us all to be concerned, and that's why we're having this discussion. Because if we don't identify the problems, we won't think of solving them. But having identified them, it doesn't mean that there aren't ways we can address these. And one thing, the same thing that could be a problem could be a solution. So as we now know that there's a lot of people who will be operating in the virtual space, we have to get involved in that space. If people are not, it's going to be less face-to-face contact, we need to engage them on the virtual platforms. So we should be ready to offer a lot more hope through virtual interventions, trainings, preventions, and even management. Already people have begun to have online consultations and things like that. So mental health should not be left out. Suicide risk management is going to be difficult because it's not exactly the same thing, but it at least is better than nothing. If we do not enter that space, those who know how, not these quacks, people who call themselves all sorts of, I'm sure most of you know these names that they call themselves these days, but the truth about it is we who are the trained professionals should enter that space and make sure that we provide people with the support, training, and care that they need. Hybrid models, we should begin to embrace that. So combination of face-to-face and virtual, all right? Combination of video platforms on telecoms, telemedicine, all of that. So people need to begin to get prepared for this. So it's not these are not things you will just enter. They also have rules. So we who are involved in care, mental health services, we also need to embrace these changes and be ready to still offer the services that we can using hybrid models. The other side, yes, I did mention that there could be healthcare fatigue. That's mostly in terms of personnel, but it's possible a number of hospitals did upgrade their facilities as a result of COVID-19. They were forced to, okay? Private and public hospitals. That's something, I mean, a silver lining, if you want to call it that, okay? That's a positive from the negative, so to say. So those are things that offer some hope that, yes, it's been gloom, but sometimes, well, there could be some booms, all right? So, but we need to be aware of this and be ready to embrace and, take control of these aspects. Other than that, I mean, we always have to remember that nobody wants to die by suicide. That's the truth, okay? Most of those who attempt suicide will tell you that they just didn't want to continue living the way they were. So it means that all we can do, anything you can do to offer hope, please, that's all some people just need. That's all people need to turn their minds around from, contemplating or planning suicide. All right, offer hope, whatever aspect, whatever sphere you belong in, whether you're in the healthcare or outside the healthcare, please just offer hope, because the single strongest predictor of suicide is hopelessness. So if we can offer ourselves hope in different forms, I'm sure that we can go a long way towards dealing and coping with the new norms, as I have mentioned. In the end, I'd like to say join the fight to prevent suicide. Join SERPIN. Yes, the world has come to, the World Health Organization target of reducing suicide by 2020. The year 2020 is coming to an end, but it's still time to do whatever you can do to join the campaign. Support SERPIN, share our hotlines, share our social media handles. You might just be helping someone who is at that point of considering suicide. So in the end, I'll just say thank you for listening, thank you for your time, and thank you for allowing me to share the little that I know. I hope we have picked on one or two things that will make us better equipped or more knowledgeable in dealing with the possible impact of the new norm, especially with regards to suicide prevention. Thank you very much.
Good evening, ladies and gentlemen. I am Dr. Aisha Tusho Armiawu, and I will be presenting the impact of COVID-19 and addressing the mental health needs. Fear, worry, and stress are normal responses to perceived or real threats. And at times, when we are faced with uncertainty like the COVID-19 or the unknown, so it is normal and understandable that people are experiencing fear in the context of COVID-19 pandemic. In addition to the fear of contracting the virus in the COVID-19 pandemic, there are significant changes to our daily lives as our movements have been restricted. So faced with these new realities of working from home, temporary unemployment, and the need to homeschool our children, lack of physical contact with family members and friends, which is one area where in psychiatry and mental health, we need total support. And with the lockdown of the pandemic, this is eroded. It is important that we look after our mental as well as our physical health, as mental health is total health, and there is no health without mental health. The coronavirus is a newly emergent infection which is caused by the novel severe acute respiratory syndrome coronavirus 2, and it first originated in December of 2019 in Wuhan. By 30th January 2020, the WHO officially declared COVID-19 pandemic as a public health emergency, which was followed by the designation as a pandemic on the 11th of March 2020. The rapid spread of COVID-19 places huge strain on capacity, responsiveness, and of course resilience of public and private healthcare system worldwide. Some of the mental health issues we are confronted with includes the uncertain prognosis, the looming severe shortage of resources for testing and treatment and for protecting responders, especially the frontline healthcare providers from the infection. With the imposition of the unfamiliar public health measures, which infringes on personal freedom, and the growing financial losses, conflicting messages from authority and the social media are among the major stressors which contribute to the widespread emotional distress and increased risk for psychiatric illness associated with the COVID-19. And therefore, healthcare providers have an important role in addressing this emotional outcome as part of a pandemic response. A recent study showed that healthcare providers revealed emotional outcomes, which include depression, irritability, confusion, anger, boredom, and the stigma which is associated with quarantine, some of which persist even after the quarantine has been lifted. So specific stressors that were identified in this study include greater duration of confinement, having inadequate supplies, difficulty securing medical care and medications, and the financial losses. Coronavirus, being a global pandemic, has already had a substantial destructive impact on our society, which poses major challenges to the provision of mental health services in time of crisis. And it carries a spectrum of an increased burden of mental health, both in terms of existing psychiatric disorder and the emerging psychological distress from the pandemic. So the three groups that can benefit from the psychological approaches to mental health and or intervention as it relates to COVID-19 includes: 1, healthcare workers who are engaged in frontline response to the pandemic and their patients. Secondly, individuals who will experience the emergence of new mental health challenges as a function of being diagnosed with the COVID-19 or losing family members and loved ones to the illness, or the psychological effect of the prolonged social distancing, which we are seeing very frequent recently. And lastly, individuals with existing mental health conditions who are either diagnosed with COVID-19 or whose experience of social distancing exacerbated the existing vulnerability. As I mentioned earlier, social support is one of the major benefits our patients get when they have mental health challenges. And of course, with the lockdown, this has been eroded. So, in addressing the mental health needs, in the early stages, mental health professionals should actively collaborate with the rest of the multi-professional healthcare system in the treatment of the immediate impact of COVID-19, which is obviously missing. Even though in the center I work, the Jos University Teaching Hospital, we have the mental health team in as frontline workers in the early stages of the illness. But unfortunately, a lot of centers do not have this. And it is very important and significant that we have the mental health team at the early stages. Then, by facilitating public mental health approaches to increasing population awareness of mental health, advocacy, organizing systems for psychologically informed intervention where people know what to do at the time of this pandemic. This may also include task shifting of mental health intervention, either by delivery through digital means or by different professional groups. Training and support for health professionals at high exposure risk to identify and manage emotional reactions that may hinder their clinical work in frontline health delivery, which includes, for instance, managing anxiety, fear of contagion, episodes of acute stress, or promoting self-care, reducing burnout and coping strategies. The main objectives of this approach is to maximize psychological resilience in as many professionals as possible who have the frontline duties during the pandemic. Importantly, in the peak of a pandemic, interventions such as psychological debriefing, critical incidents debriefing, that's critical incident stress debriefing, or any other single session intervention mandating staff to talk about their thoughts or feelings are not recommended. That said, compassionate and sensitive awareness of the impact of critical care on healthcare professionals can be used to facilitate one-on-one support, should that person wish it. Next, it is important to engage emotionally vulnerable groups, especially people with previous psychopathology. The main goal here is to support individuals undergoing COVID-19 treatment or preventive quarantine. The mental health symptoms of this group of patients with COVID-19 should be monitored. Frontline psychological support either needs to be facilitated by medical staff involved in the immediate care or be implemented directly through telecare system, which has been advocated and which we try as much as possible to do, even though we run into trouble because of an erratic network. So this has to be taken seriously. For those with serious psychiatric emergencies such as aggression, self-harm, or suicide attempts, this needs to be addressed in person. For relatives of patients who have been admitted for coronavirus infection in severe condition, or those with poor prognosis or who have already died, it is essential not to pathologize the normal emotional reaction of family members and friends, and it is important to establish clear and consensual criteria with all the professionals involved to determine whether intervention is more beneficial than not to do so. And then, at the plateau of a pandemic, and when societies begin to emerge from distancing, mental health symptoms such as hypochondriasis, insomnia, anxiety, acute stress, as well as symptoms which are consistent with post-traumatic stress disorder are expected to be present. And this is across healthcare system. So in these cases, the first line intervention should be psychological. We should try as much as possible to minimize the use of medication at this time. And special attention should be paid to potential for re-traumatization of the post-traumatic stress disorder presentation. And this is where trauma-focused therapies are implemented without adequate psychotherapeutic framework and structure. And we have to guard against the development of intervention for those that have recovered from COVID-19. They have already recovered, so there is no need for intervention because this will enhance stigmatization and it will block access of them to a new functional identity as survivors of the pandemic. So going forward, it is also crucial to ensure individuals affected by COVID-19 retain a sense of their overall identity and that this is not subsumed into an explanatory model reduced to the illness. We should understand that any intervention should be based on a thorough assessment of possible risk factors that may maintain the problem, the patient's prior state of mental health, history of bereavement, presence of a history of self-harm or suicidal behavior in both the patient and his or her family, history of previous traumas, and socioeconomic context of the patient, which is very important. We need to understand the socioeconomic context of the patient so that whatever we do, we will do it in such a way that the patient can benefit and not sink the patient into more depression. At this stage, it is also important to recognize the likely profound impact of COVID-19 on economic, social, political levels at all levels, from the individual to international, and that is why the socioeconomic status of the individual should be put into consideration. And this may therefore require mental health system to adopt new ways of working with structural inequalities emerging from the aftermath of COVID-19, which is consistent with social determinant of mental health model. So the current and the emerging challenges from the pandemic will include healthcare system deficit, both in terms of material and human resources, Then the societal underestimation of the short-term and the long-term mental health consequences of the pandemic. Poor planning and coordination of mental health interventions, especially when they are applied at different levels and by different professionals. During the pandemic, we noticed a lot of non-governmental organizations, private sector, individual coming from different angles, providing mental health needs, providing mental health care. So there was a lot of non-coordination because everybody was doing things haphazardly. So at the end of the day, we need to have a guideline which every mental health professional and every healthcare system would use during the pandemic. Any mental health intervention should be planned and coordinated, as I have mentioned, together with all the social health stakeholders involved, particularly at the primary care level and the specialized public mental health services, because this maximizes the potential for adequate continuity of care, even after acute phase of the pandemic recedes. And then finally, there is also a risk attached to early crisis response, which I mentioned led to the proliferation of intervention and framework which were associated with an oversupply of well-intentioned but potentially non-evidence-based mental health assistance, often by non-governmental organizations and third sector. This is not to say all non-governmental organization interventions are compromised, and indeed prevention in mental health is highly desirable. That said, delivery of preventive intervention must be balanced by delivery or supervision applied by appropriately qualified professionals. In conclusion, the COVID-19 pandemic and associated disruption of society poses major challenge to the provision of mental health services. These challenges include the need to identify and monitor possible risk groups for psychological morbidity, as well as exploring new ways of providing services. To take home, the Mental Health First Aid Action Plan: approach, assess, and assist with any crisis. You listen non-judgmentally, give support and information. You encourage appropriate professional help, which include referrals, and you encourage other supports. Thank you. And remember, there is no health without mental health. Thank you so much.